Good morning and welcome to Advanced BHRT for Women. Thank you all for joining us. I'm Dr. Pushpa Larson. Our presenter this morning will be Dr. Leah Paz. Please feel free to type in any questions you have during the webinar. Dr. Paz will do her best to answer questions as she goes, and there will be time for questions and answers at the end. Dr. Paz graduated from Bastyr University with her doctorate in naturopathic medicine. She works closely with Dr. Jonathan Wright and has extensive training in the use of bioidentical hormone therapy in both men and women. Dr. Paz is the senior consulting physician here at Meridian Valley Lab and has taught hundreds of doctors around the country to interpret labs and prescribe hormones, as well as training our other consulting physicians. She has co-authored several publications on hormone replacement therapy and food allergies, and Dr. Paz is passionate about helping men and women suffering from the symptoms of hormonal imbalance, menopause, and andropause. And now I'll turn this over to Dr. Paz.
Can someone just verify that you can hear me? Type in audio is fine. Okay, excellent. Thank you. Thank you, Dr. Larson. Good morning, everyone out there who's attending. Good afternoon to all of you in other time zones. Today we're going to talk about when we're focusing on lab values and hormone dosages. This includes when we should treat, understanding pertinent medical history and risks, when we should be emphasizing some of the more traditional naturopathic approaches that we can consider before going to hormones, or perhaps alongside hormones. Some of you may already be familiar with some of these nutritional and botanical solutions, but hopefully there'll be something new for everyone. Someone's asked me to speak a little louder. I'll do my best. So we're also today going to talk about optimal levels of hormones on the 24-hour urine panel, always keeping in mind that we should treat the patients, not the lab result. So that's what we've got going on here. Going to make sure that we know when to treat. Of course, look at pertinent medical history and risks. And then our treatment options include diet and lifestyle, nutraceuticals, botanicals, and then hormones. And like I said, treat the patient, not the lab values. So when to treat? Premenopause, perimenopause. Premenopause essentially is beginning of menses until the woman enters the perimenopausal range, which can be anywhere from the 30s to the 40s. Perimenopause is 5 to 10 years prior to menopause. Menopause, the definition is no menses for 1 year. And the age can vary greatly from 40 to 60. I would say the average is around 50. And somebody wanted me to speak louder. I just wanted to confirm that you can hear me now. Am I speaking loud enough? Okay, moving on. Great. So optimizing hormone production and metabolism. In premenopause, one of the main things that we encounter a number of things, but one of the very common issues that will come into your office, or a woman will come into your office with issues, is estrogen dominance. So estrogen high relative to progesterone. That can occur in all age ranges, can be due to environmental toxins. We live in an increasingly toxic world. Endocrine disruptors, pesticides, plastics, cosmetics, synthetic hormones in the meat that we eat, xenoestrogens, all of these are we have to consider. And we could do a whole talk on that, just mentioning it now. And that might be something that you should look forward to in the future here with us. And then alcohol consumption definitely increases estradiol. It interferes with the body's ability to detoxify estrogen, so then it's increasing risk for breast cancer, so increasing estradiol levels. The other thing that we might consider and see often in our office is PCOS. It goes along with estrogen dominance. You see high estrogen and high androgens. There's an increased aromatase with insulin resistance and increased adipose tissue, and then you'll see a low progesterone. So estrogen dominance, symptoms can be very wide, but some of the most common ones you'll see are migraines, PMS, infertility, PCOS, water retention, weight gain, increased blood clotting, decreased libido, fatigue, irregular menses. So the treatment is to optimize progesterone. We're going to talk about this in a little bit, but just mention it here. We want to improve estrogen detoxification, and again, there could be a whole talk just on that, but including fiber in the diet, calcium D-glucarate to help the gut to detoxify from the estrogens, and weight loss are one of the few treatment options. There are many more lifestyle and nutraceutical. Will the slides be? These slides will be made available at the end of the talk. We will have. They'll be posted, so that don't worry about having to copy all this down. We'll get those to you. So perimenopause, again, the 5 to 10 years before menopause. This, again, we're seeing progesterone decline, so then a relative estrogen dominance. Cycles may begin to shorten. You may have 20 to 21-day cycles versus a 28-day cycle. And so treatment options can include a seed rotation diet, which is something as naturopaths we go to often, especially if women are still cycling and aren't interested in hormones. Vitex Agnus cactus, which is castus, cycled days 14 through 28. That's chaste treeberry. And then low-dose progesterone, cycled again in the luteal phase, 14 through 28, to mimic nature. So there can be too much of a good thing. Progesterone excess. We don't think about it a lot, but it definitely happens, especially with prometrium dosing, which is sort of the standard of care. And that dose of 100 or 200 milligrams is far too high, generally speaking, for most women. High levels of progesterone relative to estrogen can carry some risks: depression, fatigue, decreased libido, incontinence, immune suppression, increased carbohydrate cravings, increased cortisol, insulin resistance. We just have to monitor the patient's symptoms and also make sure we monitor levels. So now we're getting into menopause. We're going to be talking largely about menopause in this talk. Treatment goals: symptom relief, improving quality of life, preservation of bone, maintaining memory, improving cognitive function, improving the cardiovascular system, protecting the cardiovascular system, improving joint mobility, relieving pain, and improving sleep. So we want to optimize and balance the hormones, and some of the hormones we look at, especially in our 24-hour urine test, are estrogens, progesterone, DHEA, testosterone, thyroid, growth hormone, cortisol, aldosterone. There's a number of other hormones that I'm not mentioning here, but we'll look at in a moment. So it's important to get a good history and assessment. Of course, we all know it's important before prescribing hormones. These things are important. It's important to look out beyond family or personal history of breast cancer, ovarian or cervical cancer. It's important to know whether the patient's mother took DES during pregnancy. DES was last used in 1971, so those women are now in their early 40s and may require more vigilant monitoring when using hormones. So that should definitely be part of your questionnaire. Every patient should get a detailed history, and that should be one of the boxes for them to check, and then just monitoring them more closely. A history of stroke, heart disease, DVT, or clotting disorders all should be taken into account, as well as osteoporosis. They may increase or decrease the desirability of using hormones. So if they have a personal history of breast cancer, you may want to, or even a family history, you may want to look for other options. And we'll talk about those other options in a little bit. So also, if someone has an autoimmune disease, you need to check for the use of prednisone or other steroids, which will increase their risk for osteoporosis and may also increase the desirability of using hormones. So hormones, not for everyone, but certainly more and more patients are asking for it, especially it's in the news, on Oprah. Dr. Oz is talking about it, so certainly we have to be ready to help our patients out. In terms of assessment, you want to make sure that you have up-to-date assessments of breast health, whether that's thermogram or mammogram, current PAP, baseline DEXA, colonoscopy in women over 50. You also want to get baseline uterine ultrasound to measure the endometrial stripe when giving estrogen. And some doctors like to get an annual endometrial stripe along with the 24-hour urine hormone profile to check levels. So now we're going to look at just some review on hormone action. So gonadotropin-releasing hormone is produced in the hypothalamus and stimulates the pituitary to secrete FSH and LH above the basal level. FSH and LH are produced in the anterior pituitary. In the first part of the cycle, FSH stimulates the ovaries to develop mature follicles. The follicles produce increasingly high levels of estrogen. The LH surge at mid-cycle stimulates the follicle to break open and discharge the ovum and follicular fluid, which contains estrogens. The follicle becomes the corpus luteum, which secretes estrogens and increasing amounts of progesterone. Estrogen, produced in the ovarian follicles, causes rapid growth of the endometrium. Rising levels have negative feedback to the hypothalamus and GnRH, which in turn inhibits production of FSH and LH. Very high estrogens reverse that effect, resulting in a sudden large release of GnRH and consequent surges in LH and FSH. Progesterone produced by the corpus luteum causes the endometrium to become thick, spongy, and glandular and receptive to a fertilized ovum. It causes breast engorgement and sensitivity and has negative feedback effect on the pituitary, causing a drop in LH, which results in the degeneration of the corpus luteum and a drop in progesterone and estrogen production. Lack of progesterone initiates menstrual flow. So that's just a review. I want to thank Dr. Pushpa Larson, who animated this slide. I think it's very beautiful, and she spent a lot of time on it. So hormonal changes in menopause. So you can see here fertile years, estrogen and progesterone in nice high levels. And in perimenopause, which I mentioned previously, that's when we see progesterone really decline. So progesterone is declining before estrogen. Then as we move into the menopausal years, we have sort of a spike and a drop pattern to menopause, or to the estrogen. So you're going to see a 75% decline in progesterone during perimenopause, so producing a relative estrogen dominance, and a 35% decline in estrogen. So now we're getting into lab values, evaluating urine hormone levels. 24-hour collection provides a complete look at all levels. Gold standard for growth hormone provides a useful metabolites to assess cancer risk, bone health, and adrenal function. It allows you to look at pathways and possible enzyme dysfunctions. It's an excellent correlation between symptoms and lab values, and excellent correlation between supplement doses, symptom control, and lab values. We're going to go through that a little bit now. So this is what our typical 24-hour urine profile looks like. It's between 4 and 5 pages, depending on which profile you get. We look, like I said, at estrogens, metabolites. We look at androgens. Here's a closer look. Female optimal levels, and this is just an overview. I don't expect, if you haven't looked at these tests before, you certainly would have to look at this a few more times to really understand it. And with every report that you do on your patient, we include a free 30-minute consultation. So we go through this step by step as many times as you need, but this is just an overview. So optimal total estrogen level for a postmenopausal woman on hormone replacement therapy would be between 30 and 60. So we're trying to get these ladies back into the luteal range again. Progesterone, we're looking between 1450 and 4000 for optimal ranges. Patients on 100 milligrams or 200 milligrams of prometrium, for instance, might be, upwards of 20,000 of progesterone. So just to keep in mind how strong those doses are. DHEA and testosterone levels, good DHEA level would be between 500 and 600. Testosterone can range anywhere between 5 and 15. On hormone replacement therapy, remember, is what I'm talking about, or for a cycling woman. Cortisol, cortisone, and cortisol metabolites, which is, we're looking at adrenal function. Cortisol around 90 is ideal, cortisone between 120 and 130, cortisol metabolites adding up between 5,000 and 8,000. Now we're looking at growth hormone. Growth hormone can vary as well. It starts to decline, of course, as we age. Around 30 starts to decline. Anywhere between 1,000 and 5,000 is good. And we have natural ways to optimize growth hormone. Of course, there's secretagogues. There's also growth hormone production or growth hormone prescription. Urinary thyroid, really a great measure of thyroid function. It's really fantastic at picking up subclinical hypothyroidism, so I put a lot of value on these results. Free T3 and free T4, both looking between 1,000 and 1,200 to be optimal. Sodium and potassium we look at for risk for developing hypertension, and we want that ratio to be 1.5. And then we look at a couple enzymes, 5-alpha reductase, we want it to be mid-range to low in women, and that has to do with PCOS, insulin resistance, hair growth on the chin, acne, that sort of thing. 11-beta hydroxysteroid dehydrogenase, those are two enzymes involved in the adrenal cortisol metabolism. We want those to be in the middle of the reference range as well. So let's move on to prescribing hormones. Every woman needs a unique balance. One prescription isn't going to be the same for every woman. So we tailor them based on labs and based on symptoms. So this is just a prescription worksheet. Certainly many of you are probably already prescribing bioidentical hormones, but for those of you who are not, this is maybe what a typical prescription worksheet would look like from your local compounding pharmacy, and they really sort of walk you through the prescription process, and most of the pharmacists at these compounding pharmacies are really willing to just hold your hand through the process as well, so I urge you to contact them if there's any question. So let's talk about estrogen. Estrogen has many, many, many functions in the body. Just a few of them here: increasing metabolic rate, improving insulin sensitivity, maintaining muscle, improving sleep, maintaining artery elasticity, maintaining skin collagen, decreasing blood pressure, helping with fine motor skills, enhancing energy, helps to preserve bone density, improves sexual interest, reduces homocysteine, decreases wrinkles, decreases the risk for colon cancer, prevents tooth loss, decreases HDL, and improves mood, and that's only a few of the many functions. So I have a question here. Let me see. Question is, I have a number of PCOS patients on birth control pills. Can urine tests have any validity or utility in these women? Well, that's a great question. What I will tell you is that when we look at 24-hour urine of women on oral contraceptive, there's endogenous suppression, so we don't get a good look at estrogens, the natural production of estrogen. We don't test for a lot of exogenous estrogens that aren't bioidentical, so it's hard. It's difficult. Although this is a useful tool, if someone is on oral contraceptive, it's probably not the best option. That doesn't mean that you can't look at the adrenal. We do have profiles that don't include estrogen, so we have an adrenal steroid profile. You can also look at the androgens. So it's not the most useful test, unfortunately. So somebody's saying there's an echo. I'm going to just move a little closer to the microphone. Is that better? Is there still an echo? Okay, I'm going to move on, and if I'm still hard to understand, please let me know. Okay, no echo. Some people are having echoes, some aren't, so I apologize for those who are. It might be an internet connection. Okay. So moving on, prescribing hormones, estrogen, Typically we use a biest. Triest is something that some people used in the past. It includes estrone. It's kind of old-fashioned and we don't really use it anymore because most women make their own estrone from estradiol just fine, so we don't find the need to include estrone. So we end up doing mostly biest, 20% estradiol, 80% estriol. Sometimes you might do a 50% estradiol, 50% estriol. And especially women who you are moving from an oral preparation to a topical preparation, you probably want to do a 50-50 because they're used to having more estrogen. So it might be you start them on the 50-50 and then you could possibly sort of, titrate them down to a 20-80. Typical starting dose is 1.25 milligrams QD, days 1 through 25. We always recommend applying the hormone to the labial mucosa. The question is, how long should they be off of birth control pills before testing for baseline? So that varies. If the patient has been on oral contraceptives for 20 years, it's going to be a longer period. But if it's somebody who's been on 5 years or less, we say, we look at the half-life and we think about washout period, and we'd say anywhere between 2 to 3 months to be certain. We want them to have a cycle and to sort of normalize a little bit. So estriol, 3 milligram suppositories every day times 2 weeks, and then 3 times a week maintenance for relief of vaginal dryness. So estriol, we think about if you're looking only to treat maybe locally vaginal dryness. Estriol is a weak estrogen, so it's not going to. It takes very high doses to take care of hot flashes. We're talking like 8 to 10 milligram dosings, and it's a relatively safe hormone, so I don't feel, especially for your breast cancer survivor patients or people who have a family history of breast cancer, you may want to think about doing estriol. Then there's also estradiol, which 5L-dot, there's tons of preparations of estradiol. Some patients come to you wanting to use their insurance, and so insurance typically does not cover compounded hormones, so you may work with them. You may give them the 5L-dot plus an estriol suppository and kind of make your own bias that way, or you might give them iodine. Iodine helps convert estrone into estriol. So there's some ways of working around that. And then there's 2-methoxyestradiol. It's a very potent anti-carcinogen. Can anybody? I just want to make sure that people can hear me. I'm getting a report that someone can't hear me. Okay, thank you. All right, moving on. 2-methoxyestradiol, 200 micrograms to 3 milligrams QD applied to the labial mucosa. Now this is a phase 2 product of estrogen. It's a methylation product. It's a very, very potent anti-carcinogen. Has no estrogenic activity. It's useful in the treatment of a patient with a family or a personal history of breast cancer. It's possible for the treatment of fibroids as well. You can find it at a couple of compounding pharmacies. The price just dropped, which is why I said between 200 micrograms and 3 milligrams. We used to give 200 microgram dosings because it was very expensive, but now the price has dropped. So, more is better with this hormone. It also has utility in patients who are going through chemo because they need less chemo when they're on the 2-methoxyestradiol. So there's a lot of emerging research on this hormone. It's even useful for men who have prostate cancer. So again, this could be a whole talk, but I urge you all to look into it because it's very interesting. So what about oral estrogen? I didn't mention oral estrogen. My opinion is that it's not worth the risk. It comes with so many risks, including increasing risk for clotting and CVA, increases CRP, decreases free testosterone because it increases sex hormone binding globulin. So some of your women on oral contraceptive or on Prempro or oral estrogen preparations may complain of sexual dysfunction, and this may be why, because their testosterone is bound up by sex hormone binding globulin. It also increases the risk for gallbladder disease, increases triglycerides, significantly increases acid reflux. It may increase the risk for liver cancer, increases production of 4-hydroxyestrone, which is a carcinogenic metabolite of estrogen, and we look at that in the 24-hour urine, and we want to minimize that as much as possible. And there are some natural ways to minimize that, like giving magnesium. Somebody's asking a question, can too much estrogen cause hot flashes? Yes, it can. It's not typically what we think about, but it's if you have too much estrogen or even too much progesterone, the woman can have hot flashes. So you just have to, that's why it's so important to get a good balance. So yes, it can cause hot flashes. My recommendation would be to bring levels down. It's an art. You have to increase one, decrease the other until the patient is feeling right. It's not one, there's not one answer. So short answer is yes, it could be. Oral estrogen also decreases growth hormone production. Progesterone. Oops. Progesterone promotes sleep if taken orally. It is a natural anxiolytic. It's a natural diuretic. And we're talking about natural progesterone here. It increases basal metabolic rate. It stimulates new bone growth. It enhances action of thyroid. It improves scalp hair growth. It has a lot of really wonderful actions. In prescribing progesterone, ideally we use compounded cream, 25 milligrams to 100 milligrams applied daily, days 14 through 28 to the labial mucosa. And again, we're trying to copy nature here. If a woman, if there's no cycling, certainly every day, there could be a case made for everyday progesterone use if they're really finding that they feel great on it. But you always want to make sure that you give a 5-day holiday somewhere in the month, and that might be on 6 days off one, it might be 5 days at the end of the cycle, but you just want to give the body a break from the constant hormonal stimulation. There's also oral micronized progesterone, 25 to 100 milligrams orally at bedtime. This enhances sleep. Oral micronized progesterone is metabolized greatly by the liver versus topically. So there's a metabolite that's produced called allopregnenolone, and it has a GABA-like effect. So we don't find as much of the hypnotic effect with the topical cream. So that's whenever I run into a case where somebody has sleep disturbance, I choose oral over topical. There's also sustained release progesterone, 25 to 100 milligrams. The best application for this is those suffering from anxiety, so it can be we can use it for an all-day calming effect. There's also progesterone troche, 25 to 100 milligram lozenges, so just a sublingual preparation. And then I did mention the prometrium, 100 milligram and 200 milligram capsules. So word on oral progesterone. Not all oral progesterone is created equally. So there's a differing degree of micronization, which is the O in OMP. So from one compounding pharmacy to another, from prometrium to compounded oral progesterone. There's a question, can you add progesterone to women with PCOS on birth control pills? Yes, certainly you can. You just, you want to look at what is in their oral contraceptive already. You don't want to overdose them on progesterone, so some preparations have progesterone, some don't. So just be aware of that. Somebody says anytime they take even a remotely small amount of progesterone, they experience severe depression, and realizing progesterone has benefits, but is there any other suggestions? So there is one suggestion, and whenever I encounter somebody who can't tolerate progesterone, I look at neurotransmitters. So I recommend doing a urine neurotransmitter on yourself and looking to see what neurotransmitters you have lacking, and that really could make all the difference. Let's see, somebody is asking a question. Since you mentioned oral estrogen decreasing free testosterone, what about using it for PCOS? I know a doctor that prescribed it for a patient, and her logic was to decrease testosterone. So yes, it will decrease free testosterone by binding up the free testosterone, but I think there are much better options for decreasing testosterone in nettles, fiber, T3. So sure, I get the thought behind it, but I think that there's a better way to treat. Rather than giving the exogenous oral estrogen, which has so many risks. There are other ways to minimize testosterone, and that we think about diet and lifestyle as well. You know, weight loss, exercise, improving blood sugar regulation, all these things can also help improve progesterone, decrease testosterone. So I think that, yes, I understand the treatment, but I would go at it in a different way. Somebody's asking me how you test neurotransmitters. That's through a urine test. If you want more information, you can contact the laboratory, and we could get that information to you on the neurotransmitters. So back to the oral progesterone, the smaller the degree of micronization, the better the progesterone will be absorbed. And that may partially explain why patients have such divergent responses when transitioning between types of progesterone, and then even from compounding pharmacy to compounding pharmacy. And we see that here because we look at so many test reports. We see, one patient is taking 50 milligrams oral micronized progesterone from one compounding pharmacy and another patient from another. And of course we have to think about, the patient's individual absorption rate, and there are many things that factor into that. But also we wonder about the degree of micronization, and each compounding pharmacy has that information, and so I urge you, if you're interested, to phone them and talk to them about it. One of my colleagues here, Dr. Kaplan, who's doing the webinar next month, he phoned, I think, University Compounding Pharmacy to speak to one of their pharmacists about the micronization, and he said, wow, nobody ever asks me about that. But I think it's really important to know really what are we giving our patients. Somebody's asking me, can you give a progesterone topical to a 14-year-old for PMS? You can. I would not personally. I wouldn't want to give a 14-year-old hormones because, it's just so early on in her life. There are many other things we can do to decrease PMS symptoms. I can't go into that right now because I just want to get going so I get through all the material. But I would urge you to look at diet and lifestyle first. And rather than giving progesterone, you can think about giving, I'm going to, in a little bit, talk about optimizing progesterone naturally. So I think that would be probably a better option for her. So now we're going to talk about testosterone. So I'm having more questions come in, and I'm just going to reserve those to the end. I just want to make sure I get through the material. So I'm making note of your questions, and I will ask them at the end of the talk. Testosterone, so premenopausally produced by the ovaries, postmenopausally produced in the adrenals. Of course, it increases libido, decreases adiposity, and increases lean muscle mass, helps to maintain bone strength, elevates neurotransmitters dopamine and norepinephrine to decrease depression. You must optimize estradiol first with testosterone replacement therapy, because without it, it can increase plaque formation. So you just want to optimize estradiol. So here is a slide sort of illustrating a female testosterone decline with age. Levels peak in the 20s and decline slowly thereafter. By menopause, a level is half of its peak. Ovaries continue to make testosterone even after estrogen production stops. Testosterone production from adrenal glands also declines with aging but continues after menopause. A little more about testosterone. These are some natural ways to improve testosterone production, so losing weight, a calorie-restricted diet, amino acid therapy, including arginine, that's supposed to say arginine, sorry, spelling error, arginine, leucine, glutamine, exercise, adequate sleep, stress reduction, and then vitamin A, zinc, and boron we think about giving to stimulate gonads to produce more hormones. So that can be for men, for women, to produce more testosterone, to produce more estrogen. The vitamin A dose is pretty high in the 10s, 20,000, something like that. Zinc, nice high dose of zinc, 50, 60 milligrams, and a couple milligrams of boron. Okay, moving on. Again, I'm seeing some more questions come in, and like I said, I will get to those at the end of the webinar. So restoring testosterone to useful levels in men and women can reverse their aging process, actually. The sexual capacity generally diminishes, and restoring testosterone levels will sometimes bring that back. So compounded cream, we think about using most, widely we use cream rather than an oral preparation. The dose is anywhere between 0.5 milligrams and 5 milligrams a day applied to the labial mucosa. You can apply testosterone directly to the clitoris occasionally to increase orgasm, but you should only do that occasionally because it will cause clitoromegaly. The other option for testosterone that is used a lot in the anti-aging world are testosterone pellets. It's something that you need to be trained in. It's an in-office minor surgical procedure where you implant a testosterone pellet into the adipose tissue, and a lot of women really like it, so that's another option for you. Moving on to DHEA. DHEA increases total testosterone and free testosterone, improves libido, it can reverse osteoporosis, it decreases TNF-alpha, and improves glucose tolerance. The thing that's important to know is that TNF-alpha inhibits conversion of DHEA sulfate to DHEA, so those with inflammatory conditions or any inflammation in their body will have a hard time using the oral form. We're going to talk about that a little bit more in a minute. DHEA also can increase sense of well-being, prevents blood clots, and also improves lean body mass. So compounded cream, typical starting dose is 5 milligrams. You can go, 5 to 15 is very typical, applied to the labial mucosa. You can go as high as 30 milligrams. It can be applied to the vagina before intercourse for increased orgasm. Not every woman needs high doses of DHEA. In fact, women are more sensitive to the effects of DHEA and need less than men do. We start men around 25. That dose is too high for women. 5 milligrams sometimes does the trick. You can also do a sublingual troche or a spray, and like I mentioned, oral is not recommended because most of it is converted to the sulfate form, and that is the inactive form. So now there's some non-hormonal supportive therapies because not every woman is a candidate for BHRT for a number of reasons. We talked about looking at the history and looking at labs and imaging. Not every woman is interested in BHRT, so we have to have other options for them. So think about diet and lifestyle with nutritional support. Sometimes that can be effective for the management of menopausal symptoms, maybe not effective in managing bone loss, but every patient is different. That's not an issue, then you may look for nutritional therapies. So let's talk about some of the herbs that can support estrogen. So we've got red clover, black cohosh, and dong quai. Nutritionally, we think about flaxseed, pumpkin seed, and soy. And then milk thistle and phyllanthus are a couple of other herbs. And there are many, many estrogenic supportive products out there, and I really like Vitanica's products. I'm not associated with the company, but I do like I like those herbal blends, so I would look into those. Nutritional support for estrogen, B complex foods, vitamin A, boron found in dried raisins and dried grapes and cherries. Magnesium found in nuts, also specific B vitamins, methyl donors glycine, and zinc, which is found in oysters. Great in this neck of the woods up here in Seattle. So now supplements to support estrogen. A couple of them here. Again, I'm not affiliated with any of these companies, but these are products we use a lot here. DIM, diindomethane, which comes from broccoli. Indole-3-carbinol, also broccoli. Fem Rebalance, which is a Vitanica product, which I mentioned the company earlier. She's got really good blends. HRT is herbal remedy from Thailand, and Dr. Wright uses that a lot with his patients who, for whatever reason, are not candidates for estrogen replacement, and this seems to work well for them. And then we consider endocrine glandular support. There are a number of desiccated glandular support products that contain pituitary, ovary, that sort of thing, so that could be an option for your patient. Moving on to progesteronic support, so this maybe would be a better option for that 14-year-old girl that somebody asked about earlier. So Vitex, Chase Treeberry would be probably a good thing for her. You may want to do like a biphasic tincture or capsule and give that to her the second half of the cycle. Wild yam, sesame seed, and sunflower seeds, which are part of the seed rotation diet. Nutritionally, we think about adequate cholesterol, and that's for all hormones, because if you don't make enough cholesterol, you can't make steroid hormone. And that might be due to, you may have malabsorption, maybe you have food allergies, and there's some reason you can't make adequate cholesterol, or maybe, low calorie intake, low protein intake. Supplements, you can think about pregnenolone. Pregnenolone is the mother hormone that's going to sort of feed into all the pathways. Possibly HCG, that has been known to increase endogenous hormone levels, and then again, endocrine glandular products. Of course, adrenal support is sort of one of the foundations that we think about treating adrenals, and of course thyroid. And here's a couple of things. There are many ways to treat the adrenals. A number of herbs: ashwagandha, rhodiola, eleutherococcus, holy basil, amala, licorice, which should be used with some caution, because it does convert inactive cortisol into active cortisol, and some people don't have enough stores, so you should be looking at a 24-hour report. Romania. Some nutritional support includes zinc, vitamin A, chromium, vitamin C, vitamin E, B vitamins, and then, of course, endocrine glandulars again. We have to think about lifestyle, stress reduction, meditation, decreased caffeine and sugar intake. So thyroid support, we want to always support the thyroid and the adrenals together as part of a comprehensive plan of balancing the endocrine system. It's really important. If we don't balance the thyroid and the adrenals, the patient doesn't respond as well to your hormone replacement therapy and your balancing. So iodine, zinc, vitamin A, iron, selenium, tyrosine, vitamin C, D, E, amino acids, essential fatty acids. So these are some of nutritional ways to support the thyroid. And of course there's Armour Thyroid as well, which we use a lot and recommend a lot. Moving on to another part of balancing hormones and improving quality of life are strategies for improving sexual health and desire, what every woman wants, every man wants. I think everybody wants that. So sexual dysfunction can be categorized in a couple of ways: lack of desire, poor vaginal health, inability to orgasm. Declining estrogen levels can cause a decreased supply to the vagina. This decreases blood flow and can cause clitoral atrophy. It also can affect the vaginal lubrication, which can make sex less pleasurable. Somebody is asking, I'll answer this question quickly, is there any evidence to support of the use of non-hormonal glandular products? There's a big debate on that. Some people love them, some people don't. In terms of evidence, I can tell you that from looking at these 24-hour urine reports, I do see when people put their patients on either like a isocort, cortisol, or even a glandular product, we do see improvement. But there's so many factors that go into what's impacting the adrenals. It's really a hard thing to measure. So I think the jury's still out on that. I think it's a personal preference. In America, sexual dysfunction affects 40 million women. That's a lot of women. A high incidence of these women have fibromyalgia. 31% of women would report having low libido. 42% would have another sexual dysfunction. We have to consider that a lot of medications that our patients are on affect sexual function, and some of them are antipsychotics, SSRIs, beta blockers, oral contraceptives, like I mentioned before, because it increases sex hormone binding globulin, antihistamines. The list goes on and on. So, when we're... Can everybody hear me? Somebody's reporting that the sound is cut out. I'm sorry I keep asking you this. Thank you. Sounds good. Thank you. So we have to consider when evaluating somebody for having libido issue, we have to look at their whole medication list and start there first. Somebody's mentioning that isocort does have a significant hormone content. Yes. Each dose, I think, can be 2.5 milligram dosing. So certainly there's a lot of cortisol in that product. So we'd probably see a greater impact using isocort versus using a glandular product. So let's talk about oxytocin, the love drug. There's a lot of talk about oxytocin these days. It's sort of the latest and greatest thing in the anti-aging world. It's an essential hormone for all of us. It's been theorized that 1/3 of all people can benefit from oxytocin supplementation since there's a deficiency. Not only does it increase intimacy, but it increases sexual desire. It makes lovers more attracted to one another, making them better ambassadors of love for their family and friends. Couple quick facts on oxytocin. It's a nonapeptide hormone secreted from the posterior pituitary. It promotes milk letdown in uterine contractions, and it's tied to sophisticated human social interactions. Oxytocin and the human interaction. So it's associated with interpersonal trust, memory for positive emotions, romantic and parental attachment, fear regulation and anxiety control, social self-perception, increased pleasure emotions via beta endorphins, and increased sociability and extrovertedness. Some indications for use of oxytocin for sexual dysfunction, low libido and inability to orgasm. Some emerging indications: autism, schizophrenia, and major depression. It's very interesting. So some symptoms of oxytocin deficiency, they are very wide. Low libido, poor mood, irritability, joylessness, insomnia, affectionless, weak or absent orgasm, sex feels like a chore, excessive anxiety, decreased vaginal secretions, short or absent orgasm, decreased erection for men, decreased ability to ejaculate or low ejaculate volume. Somebody's asking me if there's been any clinical trials of oxytocin with autism spectrum disorder patients. And I believe so. If you want, I can get you that information. If you might send us an email to info@meridianvalleylab.com, I can give you that information. So a little bit more about oxytocin. It increases vaginal lubrication, decreases orgasmic threshold. Women who experience multiple orgasms have increased plasma oxytocin. Oxytocin does not cause contractions in a non-pregnant uterus. That's very important to let your patients know. Oxytocin receptors are not expressed until 18 weeks gestation. So clearly you don't want to use it in a pregnant woman, but it's not going to affect a non-pregnant woman. Somebody's asking if we have a male hormone web seminar, and we actually do. It's coming up next month on the 29th, and Dr. Michael Kaplan is going to be doing that. So he's going to do the male counterpart to what I'm doing here. So yeah, that's coming up, in the very last slide in this presentation will tell you more about that. So in men, an orgasm, after orgasm, they lose interest in sex and get sleepy due to a surge in prolactin, but women, interesting, the sexual desire continues until they find satisfaction. The Dr. Jorge Fleches, I'm not sure if any of you have heard of him, but he brought oxytocin into practice, first with his fibromyalgia patients. And what he does, I find it very fascinating. He'll give a woman an intramuscular oxytocin shot in the office to see if the treatment will even work for them. So he waits for 5 minutes to see if he sees auricular flushing, so flushing of the ears. And if there is a red color there, then that person is responsive. If there is no response, then he looks for the reason. There are many reasons. It could be maybe they have high prolactin. There could be drug inhibition, low DHEA, low testosterone, low amino acids. So I don't think, he doesn't continue to use the IM preparation, but that's just a little in-office test. What dose? I don't remember the dose. Do you remember that? I can look that up for you, the dose, and someone will, actually I'll have someone look that up right now. So moving on, oxytocin can be inhibited. Oh, somebody's saying 10 IU for the IM shot. So somebody answered that. Thank you very much. Thank you. And I think he also put some lidocaine in it as well. Oxytocin is inhibited by stress, opioids, and opioid peptides, fear, and anger. Plasma oxytocin levels will increase in women during sexual arousal. It relates to female genital lubrication, and it spikes immediately after orgasm. Some ways to raise endogenous oxytocin: breastfeeding, suckling, warm touch from a partner, relationships with high partner support, singing, regular exercise, massage, listening to music, warm climate, vaginal distension. So now let's talk a little bit about supplementation. So you can find sublingual tabs by many compounding pharmacies. They come in a number of flavors. You take 10 to 50 units approximately 30 minutes prior to intimacy, and typically what you're doing is trying different dosings to see what works right for the patients. I'd say a typical dose is probably 50 units. You can give the patient 10 units daily maintenance dose, and then an additional 50 units episodically before a sexual event. There's also intranasal and sub-Q IM preparations. And I just wanted to say thank you to Craig at Custom Prescriptions. He helped me a lot in the preparation of this talk, and he's very knowledgeable about oxytocin. So if you have any more questions about how to give that to your patients, how it's formulated, you can phone him. I gave his phone number right there. Precautions. Of course, there are some precautions. Oxytocin may inhibit cortisol at treatment doses, so patients who already are adrenally wiped out or have Addison's disease would not be a candidate for this therapy. It can cause edema due to its similar structure to vasopressin. Still, more research is needed. This is emerging field in the anti-aging community, so it's being used, but it's relatively safe. It should be noted that it doesn't produce a drug-like high and is a very low potential for abuse. So there's also some topical intimacy enhancers. There's something called Scream Cream, which Dr. Pam Smith talks a lot about in her talks. And it's basically a vasodilator. So arginine and aminophylline are two of the main active ingredients. This is available at any compounding pharmacy. It's a newer product, so you probably will have to give them the formula or put them in touch with the person who developed it. But patients report success and increases blood flow and sensitivity and orgasmic potential. You apply 5 minutes prior to sexual activity, and you can find it through your compounding pharmacy. There's another product out there that's called Zestra. It's a botanical topical product. It has evening primrose and borage oil, and it's got a couple herbs: angelica, coleus forscoli, theobromine. It's got some antioxidants, and basically it enhances sexual pleasure, and it's available over the counter. Moving on. But what method is best for your patients? If we're looking between topical enhancers and oxytocin, the topical enhancer is localized, improves orgasm. The oxytocin is more systemic, and it not only is it improving orgasm, it helps attenuate fear and anxiety, improves positive feelings and trust. You have to consider which approach is indicated for the individual. Beyond the topical enhancers and oxytocin, there's some herbs. We can also always consider herbal supplementation. Some androgenic herbs are ashwagandha, tribulus, serenoa, smilax, damiana, and then aphrodisiac herbs. Damiana again, yohimbe, Miria puama, and tonka ali. Yohimbe increases genital blood flow and sexual sensitivity and excitation. The Miria puma increases dopamine. So that's another thing to think about. I mean, what's happening with the neurotransmitters, and things that improve dopamine generally will work as aphrodisiacs. So another herb to consider is ginkgo biloba. It improves libido in women taking SSRIs. So in conclusion, a thorough history, looking for hidden risk factors, complete assessment with annual updates, put in the foundation first, diet, exercise, sleep, add specific nutrients as needed, don't forget the power of botanical medicine, make use of the mind-body connection, treat the patient, not the numbers, and there are many options for improving sexual satisfaction, and we always, of course, have to start with what's the relationship like. I mean, if somebody is, has a poor, rocky relationship, then that might be the place to start rather than applying hormones or topical substances or herbs. You may want to first start with some counseling. So now I'm going to take some questions. Let's see. So there's a question about a postmenopausal patient who requires high doses of oral progesterone, 400 milligrams daily, to prevent breast tenderness using 6 milligrams biased. What would you recommend to help this patient? Well, I probably, if this were my patient, would bring everything back down to sort of baseline levels. 6 milligrams of biased is a little bit high, so I would probably reduce biased. Maybe, what you may do is sort of take them off everything, do a detox. It's not possible with all patients. Some patients will not allow you to take them off their hormone, but work on the liver, reintroduce the hormones at a lower dose, a 1.25 milligram to the labia. For most women, I find that 2.5 milligrams is the highest I have to go. So the woman on 6 milligrams, I'm wondering if what you're doing is having to increase oral progesterone more and more and more because her dose of biased is too high to begin with. So that's where I'd start. Let's see, I think there's another question. If a patient has continuous edema in hands and water retention from BHRT, what would you evaluate? I would look at, of course, cardiovascular health, that goes without saying, but, progesterone is a natural diuretic, so I would look to see where their progesterone levels were, and if their progesterone levels are not adequate, then certainly adding some progesterone can really, really bring down that edema. There's a question, is this webinar accessible in your archives? It is not yet, but it will be soon. I think in the next few days it'll be archived, available for watching again. I think it's going to be on YouTube. What if edema happens after applying progesterone? Interesting. I think then I might look to see what's happening with the balance with the estrogen, and also look into different delivery method of progesterone, maybe oral progesterone, maybe pregnenolone, maybe also giving them a diuretic herb with it, a gentle diuretic like dandelion or something like that. Okay, somebody said, on what basis do you decide the dose of labial methoxyestradiol as 200 micrograms to 3 milligrams is a broad dose range? Yes, this is true. That's a broad dose range. So the theory behind it is it's a very potent anti-carcinogen. It doesn't have any estrogenic activity, so the higher the better. The reason I give a dose starting at 200 micrograms is because that's what we've been using at the Tahoma Clinic with Dr. Wright, but since the price has dropped, we're now using a higher milligram dose. So if the patient can afford it, I would go higher with 1 to 3 milligram dosing. Liver always needs to be fixed first. Someone said, yeah, most definitely for the edema. Somebody's asking, maybe they meant pregnenolone better topical or oral? Depends if you're trying to get at the neurotransmitter effect of the pregnenolone, I would probably do oral. I don't really use a lot of topical pregnenolone. I'm sure that the compounding pharmacy can make it, so I can't really speak to that. Somebody's asking, in what circumstances do you use 2-methoxyestradiol? When a patient has fibroids, if a patient has family history or personal history of breast cancer, in a patient, a prostate cancer patient, a male prostate cancer patient, those are probably the top 3 uses I think I would try. Somebody's asking, is there a source to find doctors who follow these therapies that use Meridian Valley Labs on the East Coast? If you give us a call, the customer service, we have a large database of doctors using our tests. I'll give you the phone number. It's 425-271-8689. So just give us a call. The customer service person can help you with that. Let's see. Why use E2 at all in a prostate cancer patient? Because it is very potent anti-carcinogen. The other thing you want to look at is Yeah, so I just want to clarify, we're not talking about estradiol in a prostate cancer patient. We're talking about 2-methoxyestradiol. has no estrogenic activity. Another thing you want to look at with a prostate cancer patient is their level of 3-beta-adiol. We have a test, a blood test that looks at that because that metabolite stimulates estrogen beta receptors, which is potent, very potent in decreasing risk for prostate cancer. When to use oxytocin in men? It's the same indication, men for women. I'm talking about women today, so I certainly focused on women, but it's the same: inability to orgasm, low ejaculate volume, erectile dysfunction. So 2-methoxyestradiol has no estrogenic activity. Yes, that's true. That was a question. Somebody's mentioning that for cancer you need modified citrus pectin. Yes, that's true. If you want to make an appointment with me in my office, where do we ask for? So I'm not. This is not for. I'm not the doctor here treating the patients. This talk is mainly meant for doctors or other practitioners. What I recommend, if you want to make an appointment with somebody who follows these sort of ideas and theories, I would recommend contacting the Tahoma Clinic, Tahoma Clinic. All the doctors are well versed in all these therapies. Any other questions? So I just wanted to point out to you, somebody already asked about the male counterpart to this, and yes, Dr. Kaplan will be doing a male version of this with even more interesting tidbits, more than just herbs and oxytocin. He's talking a lot about prostate health and all sorts of interesting things. So this prostate talk that was we sort of touched on here, Dr. Kaplan will go very deeply into that. So March 29th. And I urge you to just go onto our website, just like you registered for this webinar, and register for that. Somebody asked me if this webinar is accessible in the archives, and it's not yet, but it will be soon. Will we be able to listen to this lecture recorded? Yes, it's going to be a YouTube video, so you can listen to the whole thing with the talk and the slides and all of that. What time on the 29th? It's at 11, right? 11 o'clock, same time. Pacific time. The handouts, if you contact us, we will send you the slides. If anybody wants that, I'm happy to give you the slides. Any other questions? You're all welcome. Thank you so much for your participation. And I hope you have a wonderful phone number of custom prescriptions. Let me give you that. It was on an earlier slide. Let me see. Custom prescriptions, you're going to talk to Craig. The phone number is 877-371-3661. Thank you that the website is inaccurate. It's saying that the next webinar is February 20th with Dr. Kaplan, which is not true. It's actually March 29th with Dr. Kaplan. Can you fix the website? It's got the wrong webinar date. All right. Thank you so much, and I hope you all have a wonderful week.